Hello and welcome to yet another YouTube video discussing endometriosis related research. This time I will be discussing a recent paper that comes from France. The authors looked at a potential link between the severity of endometriosis symptoms and the outcomes of artificial reproduction in patients with endometriosis related infertility. This is an interesting question, and it is a logical one to ask because the rationale behind it is the role of inflammation. In a sense, we know that patients with endometriosis present with chronic inflammation, and this chronic inflammation appears to play a key role in both pain as well as infertility. So it is logical then to ask as to whether there is actually a link between pain and artificial reproduction outcome. It was a retrospective study, meaning that the authors looked at data backwards, and they included 354 patients in 711 cycles of IVF that happened between 2014 and 2021 in a large tertiary referral center in Paris, France. It is interesting that only 1 in 3 patients had definitively endometriosis, which means endometriosis confirmed by histology from previous surgery. 2 out of 3 patients had endometriosis based on expert imaging, be it either ultrasound or magnetic resonance imaging, MRI. How did the authors assess the severity of the pain? They assessed it using a very well-known tool, which is the visual analog scale, VAS, and they identified severe pain as one being VAS more than 7. It is interesting to see that 2 out of 3 of the patients that underwent primary IVF rather than surgery had severe pain. The type of the disease, 9 out of 10 patients had deep endometriosis, so we're talking about the large majority of those patients had severe disease, with 2 out of 3 of those having some form of bowel infiltration by endometriosis. 1 out of 10 had coexistent endometrioma, and adenomyosis, which we know that plays a key role in infertility, was present in 2 out of 3 cases. The primary outcome of interest, what the authors were interested to see, were actually the cumulative live birth rate, meaning what was the rate, not the pregnancy rate as such, but the rate of live births, pregnancies that led to a live birth through those IVFs. And they reported a high cumulative live birth rate of 64% with no complications relevant to endometriosis during the IVF. And the important finding here is that there was no difference when they did their statistical analysis between patients that had severe symptoms and those that did not have severe symptoms. So this is the primary finding of this research, is to say that the severity of the symptoms does not play a role in the outcome of IVF. The only factors that were important was a low AMH, a low level of anti-Müllerian hormone, that being less than 1.2 nanograms per ml, and a maternal age, a woman's age of more than 35 years of age. What is also interesting is that the authors found that a younger age and more severe endometriosis were linked with more severe pain. And in those patients with more severe pain, they had also a lower clinical pregnancy rate as well as a lower miscarriage rate, leading essentially to the same live birth rate. Of course, when we're discussing original research, one needs to be careful to identify and discuss the limitations here. The major limitation of that study, in my view and also the author's view, is the lack of histology in the vast majority of the patients. 2 out of 3 patients did not have histologically confirmed endometriosis. So that is a concern. Although we know that imaging can give us excellent answers, it does not replace histology, of course. The data, of course, come from a specialist center of expertise, which means that the generalizability of the results may not be there, which means that less experienced centers may not have as good results. We also know that IVF results largely depend on the performance of the laboratory itself. And of course, evaluation of the pain was made by a single tool, the VAS tool, whereas there are other tools that can be used. So that takes us to the end of this interesting study, and I congratulate the authors on performing that study. There's certain things, however, that need to be discussed here, and that takes me here to briefly touch upon the role of surgery versus ART in endometriosis-related infertility, particularly in patients with deep endometriosis and severe symptoms. The jury between IVF and surgery, what to do first, is still out, which means that there's no single best answer to answer this question. Which one to do first. However, there are certain facts that we need to acknowledge. One is surgery. Surgery, we know that in experienced hands can offer excellent symptomatic relief of the pain. And research suggests that in appropriately selected cases, spontaneous conception after surgery can reach up to 60 or 70% of cases, which is quite a high number. Of course, in patients where spontaneous conception after surgery is not deemed to be likely, either by the surgeon's experience or the use of appropriate tools such as the endometriosis fertility index, the patient can be referred to IVF. The main argument against surgery would be the risk of complication, which could touch up to 5 or 10% of those cases. However, we do know that, of course, a risk of complication largely depends on the skill of the surgeon as well. On the other hand, IVF, we know that can achieve excellent or very good reproductive outcomes. We can have live birth rates 60-70% after 1 to 4 IVF cycles, according to recent research. However, symptoms may worsen during IVF, and potentially severe disease can progress. Now, of course, we need to let our patients know that severe complications of endometriosis are not common during IVF. Thankfully, in this research, the authors reported no such complications. However, they are not 0%, and we need to acknowledge that. If one looks at the relevant case report, which I'm presenting here, some of them not so long ago, it can be seen that severe complications such as ureteric obstruction, bowel perforation, bowel obstruction can occur in patients with large endometriosis lesions that undergo primary IVF. As I said, these are uncommon. However, I suspect that provided that these patients are given that information, some of them may decide to undergo primary surgery, wanting to avoid that risk. So, in conclusion, I would say that, and I agree with the authors that there's no right or wrong answer. The decision should be made by the patient. Our role, in the absence of concrete data, our role as clinician is to present the available evidence to the patient and allow them to make an informed decision for themselves. However, it is my personal view, and I again repeat that this is just my personal view, that in patients with severe disease and severe symptoms, it is reasonable to offer or at least discuss thoroughly appropriate excision of endometriosis first. Following surgery, then the surgeon may discuss with the patient either to undergo attempts for spontaneous conception for 9 to 12 months, provided that there are good chances of that, or if the patient's pelvis is not left in a good condition, or if there are coexistent factors such as a male factor or severe adenomyosis, etc., then it may be reasonable to refer the patient for IVF, but after surgery, after we have made sure that those symptoms have been improved, after we have made sure that the severe disease has been eradicated appropriately. This is my personal view, and I will open the comments so that patients or clinicians can feel free to express their opinions and maybe open a discussion. It is an open discussion that when we don't have yet an answer, both options are have the pros and cons, surgery and IVF, in patients with severe endometriosis related infertility. That concludes this video. Feel free to like, share, and subscribe to my channel if you wish to see more videos in the near future. Thank you so much, and a Happy New Year.